Hello everyone and welcome to another high yield USMLE question. This is going to be 63rd question in the medicalized question bank. Today we are going to talk about pulmonology. So question is going to be very high yield for USMLE Step 2 CK takers and also USMLE Step 3 for the day 2 of USMLE Step 3 and also the CCS cases. So we have a 65-year-old male comes to the emergency department with sudden onset shortness of breath, sudden onset chest pain after motor vehicle collision. Blood pressure is very low here, so it's going to be hemodynamically unstable. If it is less than 90, that's hemodynamically unstable. The patient's blood pressure is, the pulse is high, which is tachycardic, and that's because of sympathetic, it's increased sympathetic outflow because of the hypotension. The beta receptors sense the low blood pressure, increasing the sympathetic outflow, causing tachycardia. So on examination, the patient is in acute distress with elevated JVP, and right side is hyperresonant to percussion. So this is tension pneumothorax, easy scenario. So now most people, this is the reason that this question is high yield is because of the similarity with the cardiac tamponade scenario. So here, elevated JVP, hypotension, and the third thing is the muffled heart sound. These three are actually Beck's triad of the cardiac tamponade. Now here, remember the muffled heart sound they can easily give as well, because if you in tension pneumothorax you have more air in the pleura, and if you have more air in the pleura, it can actually block those sounds, those heart sounds, so you can get muffled heart sound there as well. So then how do you differentiate on a board question between tension pneumothorax and the cardiac tamponade? And the answer is here. This is sort of like a buzzword. If they say hyperresonant to percussion, it is done. The question is basically done. This is tension pneumothorax, not cardiac tamponade. So very high yield. Now here, why does the tension pneumothorax cause the elevated JVP? So if this is your superior vena cava and this is your heart, so now this is, let's say, the right atrium. So what happened here is that you have on the side here your lung, and so in the pleura you have a lot of pressure because of the air. There is increased air here in the pleura, and it's going to be stretched, and it's going to eventually compress the superior vena cava, and that's going to cause backup of blood here, leading to jugular venous distension. So this blood cannot come here into the right atrium, stays up, resulting in elevated JVP. Now, so what should you do next in this patient? So chest X-ray is wrong answer because this patient is hemodynamically unstable. We don't have time for chest X-ray. Chest X-ray would have been the right answer if it was hemodynamically stable, like 120, 80 blood pressure, 110, 80, for example. Transesophageal echo, wrong answer. So remember, transesophageal echo, one high yield scenario they usually give is the endocarditis, because it is very, very good at visualizing these the vegetations. So you need two things in endocarditis diagnosis. One is visualization of the vegetation, and the second thing is blood culture positivity from at least 3 different venous section sites. So now, you still need to first do transthoracic echo there. It's just that if you have a high suspicion and the transthoracic echo is negative, then you go to transesophageal echo. If you have high suspicion, even after a negative transthoracic. So transthoracic is often negative because it's very poor at detecting those vegetations. Now, needle decompression here is the right answer. Thoracotomy is going to be more aggressive here. It's going to be wrong answer. Fluids is the wrong answer here. Now, after, let's say, they give you the same scenario and they say now we did chest decompression, so what to do next? Next thing, do chest tube placement, and then you do X-ray. Remember, then you do X-ray. So first needle decompression in hemodynamically unstable patient with tension pneumothorax, then chest tube, then chest X-ray. Now why X-ray towards the end? The reason is because if X-ray is towards the end, it's gonna help you confirm the diagnosis, and also it's gonna confirm the right positioning of the chest tube. So the position of the chest tube is also confirmed with the chest X-ray. So if this was a stable patient, then obviously X-ray would have been the right answer here. Now another tip or another point that I'm going to add here is that, let's say they say that the chest tube that is placed is having excess air leak. So if there is like excess air then necessary for a tension pneumothorax, and now you should suspect. Remember, excess air leak from a chest tube is a buzzword for probably a bronchial rupture. Very high yield to know. Bronchial rupture. The next step is look for a bronchial rupture. So this is pneumothorax. Make sure to know on board questions, differentiate it from the Beck's triad of the tension of the cardiac tamponade. And remember, this is one cause of the obstructive shock. So now here, because there is obstruction to inflow of the heart of the blood into the right atrium. The blood cannot go into the left ventricle because there is no blood in the right ventricle. If there is no blood in the right ventricle, no blood in the left ventricle, cardiac output severely drops. If the cardiac output drops, what happens? Blood pressure is severely low. So you get hypotension, and that can lead to shock, and this is obstructive shock. Classic example of obstructive shock is actually pulmonary embolism. So I hope this video was helpful, and if anyone is enjoying these videos of this channel and want to keep it afloat, and you want me to continue putting effort into this question, consider donating, and links will be in the description. You can donate at Buy Me a Coffee, link will be in the description. Also, if anyone requires tutoring, they can email me here as well. See you in the next video.